All right, everyone. We're 6 o'clock on the dot. Going to go ahead and get us going. First off, thank you so much for taking the time out of your busy schedule, your busy lives to be here with us this evening. Very excited to have Dr. Alqadoumi presenting this evening, but I wanted to take just a brief moment to introduce myself and Maxius to everyone. Maxius Dental is first and foremost, very exciting news. In September of 24, Maxius acquired BioExclude from Snoasis Medical. So Maxius Dental is now the sole provider of BioExclude. If you are not familiar with BioExclude, you will after the next 60 minutes. So pretty confident in that. But Maxius Dental has a full portfolio of regenerative products. Maxius is a division of Solvita Corporation, which is a non-for-profit tissue bank located in Dayton, Ohio. Again, if you're not familiar with Maxius Dental, I really encourage you to take the opportunity to jump onto our website, maxiusdental.com, learn a little bit more about us, our mission. I think you will just very intriguing to figure out where your bone comes from and our mission and what we try to do as an organization. So I really encourage you to do that. And with that, I want to go ahead and turn it over to Dr. Alqadoumi. I've had the pleasure of getting to know him over the last, has it been 6 years now?
Yep, almost
It's
6 years now.
been a while. So Dr. Alqadoumi got his first DDS at the University of Jordan in 2012, followed by a second DDS at Loma Linda in 2016. Then stayed at Loma Linda to get his grad perio certificate. He has a number of titles, faculty, private practice, clinician, all around great guy. But I think his favorite title is probably dad, if I'm guessing. So with that, Dr. Alqadoumi, I'm going to go ahead and turn it over to you.
Awesome. Thank you very much, Matt, and good evening, everyone. And I would first start by thanking Matt and everybody at Maxius for this kind invitation. It's a true pleasure and honor to be with you here for the next hour to discuss a topic that is a very important topic, and hopefully we can get some knowledge out of this, where we want to discuss the innovations in sinus surgery, and we're going to use the amnion-chorion membrane to repair the Schneiderian membrane perforation. So when we discuss sinus augmentation, we all know it's a procedure that we do in the posterior maxilla to get more vertical bone height to place an implant. And that could be, depending on how much available bone we have, either a lateral window where we get a direct access to the sinus cavity through the lateral wall of the sinus, and we elevate the sinus membrane and we get a full direct visualization of that membrane. Usually that is done, what research suggests is when we have less than 5 millimeter of residual bone, and we elevate it all the way to the medial wall, and we anticipate what implant size we want to get in the future. And as you can see here, we have a 15 millimeter of bone that we have created, and we're ready to place the implant later on. The other technique is the crestal sinus augmentation, which is indicated when we have 6 millimeter of residual bone. And there are a lot of techniques since this came out back in the 90s, where they discuss what methods and techniques that are out there to do a crestal sinus augmentation. But generally speaking, as I mentioned, 6 millimeter of residual bone. Here you can see the osseodensification technique, which also I'll allude to that later in my presentation. But it's very, very important that we know when do we use each one, why do I use it, and how we get to the results and the outcome that will be more predictable most of the time. But no matter how good you are and no matter how expert you are, you're going to run through problems. You're going to run through sinus membrane perforation, whether you're doing a lateral window or you're doing a crestal sinus approach, and you're going to have a perforation. So what is important as a clinician, first, is to prevent these problems from happening. And second, if they do happen, know how to manage it. Now, when we look at the lateral window sinus augmentation, the literature has done a lot of studies about it because we have better visibility. We can see better. And we can see that 10 to 35% of the time we get a perforation of the sinus membrane. And that's the very most common complication. That's a lot of things led Houry and Prosaus in their articles to conclude that there is a correlation between implant failure and sinus membrane perforation. And some of those symptoms that happen or signs is that post-operatively, after we have a perforation, we may get a complication like acute or chronic sinus infection, swelling, bleeding, or loss of the bone graft, which eventually will lead maybe to an implant failure. That's why those studies, they kind of linked implant failure to sinus membrane perforation. But a most recent systematic review and meta-analysis, they looked at the Schneiderian membrane perforation, and they stated as long as that perforation is repaired, it does not appear to negatively affect the outcome and the survival of the implant. And this is a very important point that I want to insist on today, that membrane perforation should not be considered a reason for you to abort the procedure, okay? Or a contraindication to place implant. I'll show you some techniques, some methods, how we can overcome that one and proceed forward with our sinus augmentation. Now, when it comes to the osteotome technique or the crestal sinus augmentation, we know from a systematic review and meta-analysis, we have high success and survival rate, but we do not have a lot of reports that discuss the incidence of perforation, okay? And why is that? For obvious reasons. We have limited visibility, especially if you look at the previous studies that were done before the osteodensification technique. I would say, generally speaking, you have limited visibility, you have limited access to see. So one of the studies reported up to 21% of perforation of the sinus membrane during crestal sinus approach. So that's what intrigued us at Loma Linda to do multiple cadaver studies. And those three studies that I will discuss now, they all looked at crestal sinus augmentation techniques and the incidence of sinus membrane perforation, okay, which is our topic today, and how to repair. And in this study by Garbacha, Dr. Garbacha, she did on compare three techniques of crestal sinus floor elevation, and she used a real-time sinus endoscopy. And which she had those cadaver heads standardized that we are lifting 5 millimeter and having a residual of 5 millimeter. So we're kind of trying to defy what has been approved and accepted in the literature, having a residual of 6 millimeter bone and lifting a safety margin of 4 by lifting 5 millimeter. And the rate of perforation was 40%. Now, another study by Dr. Abdul Karim Hamidan, where he compared two techniques, the the internal sinus manipulation technique and the osteotome technique. And you can see this technique by Yamada, the internal sinus manipulation technique. He uses special instruments, and they did a real-time sinus endoscopy, as you can see in these videos. Thank you to Dr. Abdul Karim for providing me with these, that will show you what is happening in a real time as you're doing your crestal sinus augmentation with this technique. So on the left side of the screen, you see that there is no perforation as they're doing that. And on the right of the screen, if I fast forward a little bit, you will see as that instrument is going in and it's thinning out that membrane, it will perforate. Now, why did it happen on the right side and why did not happen on the left side? A lot of reasons, a lot of factors that I will discuss with you today. And we want to see how we can get to a conclusion that will help us in our practice to kind of get more of a standardized rules, let's say, or things that we look at to help us reduce the problems. Now, this comes my research that I did on human cadavers, but the difference here is that we did not do a real-time endoscopy, but we got a saw and we cut the cadaver heads to expose the sinus cavity and get let's call it a real-time visibility with our eyes and video recording to see what happens when we do the osteodensification technique and compare it to the osteotome technique. And we looked at when did that perforation happen? Did it happen at the time of drilling? Did it happen at the time we placed the implant? Or did it happen at the time of bone graft placement? And here we did similar to what Dr. Garbacha did, which we started with 5 millimeter residual bone. And I can tell you that the incidence of perforation was similar to what Dr. Garbacha got, almost 40%. And most of that perforation happened, as you can see in this video, at the time of implant placement. And why does that happen? If you take a CT scan or if you take a periapical x-ray, I bet there is no way that you can detect that you have a perforation with that one. You're going to see a nice dome and you're going to think that you have no perforation. Now, how important is this perforation? How much clinical problems it will do? I have no clue. Every patient is different, everybody heals differently. But our job as clinicians is to make sure that we prevent that, we decrease the chance for that. We know what we know so far from the literature, and we want to do our best to reduce these problems and reduce morbidity afterwards. Nowadays, with the osteodensification technique, you get a clear circular osteotomy, and you break the sinus floor, so you have direct access to the sinus membrane. So as you can see in this video, you can clearly see the sinus membrane. You can see the gray color of the sinus membrane, so you have better visibility to see and detect the perforation more than what we used to have before with different techniques. So how do we diagnose the sinus membrane perforation? Either direct visualization, we look at it, we see it, lateral window, it's much easier. But as I mentioned, nowadays with crestal sinus augmentation, we are able to see better. Endoscopy, you don't have to, this is more invasive, mostly for research purposes, yes, but not every single patient who's going to walk in and you do a sinus augmentation, you're going to do an endoscopy at the same time. Bleeding or fluid leakage. This is my favorite. And during the procedure, my assistants can swear to you that all the time I'm asking the patient if they feel anything going to their nose, any fluid, any liquid, any bleeding. This is a very good symptom because that's something that the patient will report. Sign is what I will see with the direct visualization and with the radiographic evaluation. So that symptoms helps me if I don't see a perforation to know that there is a possible perforation. Okay. Radiographic evaluation, as I mentioned, CBCT can be used, X-ray can be used. CBCT might be more accurate in detecting perforation than X-ray, but still, as I mentioned, we have, and I will discuss that further forward from Dr. Abdulkarim Hamidan's study, a lot of false negative readings from CBCT. Meanwhile, we know that there's a perforation, but CBCT did not show it. Now, some may say or recommend to look for when you ask the patient to breathe, if the sinus membrane goes up and down, this is most probably that it is sealed and we have no perforation. And if you ask Michael Picus, he's gonna love that question, and I'll show you later on in my slides. Now, why do we have or we get perforations? Those are the reasons that I can think of as of 2025, the reasons that I always look at, whether I'm doing a crestal sinus approach or a lateral window, and I want to make sure I cross the dots on all of these and check marks to make sure that I review them. Having a minimum alveolar height and doing the incorrect technique may increase the risk of perforation. Having septum also in the sinus cavity increase the risk of perforation. The thickness of the Schneiderian membrane, and we will discuss that. The surgical technique, including whatever related to the surgeon experience, the design of the surgery, the instruments that they use could increase the risk of perforation. The angle of the palatonasal recess, and we will discuss that, and the angle of the sinus floor. And this is very, very important. I'm very passionate about it. That's why you'll see me talking a lot about this. And I want everybody to keep attention when I talk about that one. And last but not least, the cortical wall thickness. So when we look at the palatonasal recess, that angulation, if you see where my star is, this is the angle that I want to keep an eye on when I'm doing a lateral window sinus augmentation. Because as we know, we're going to go from the lateral wall all the way to the medial wall, and we want to lift over, maybe sometimes beyond that palatonasal recess. And a lot of studies showed that if we have an acute angle was less than 30 degrees, we see up to 62%, almost 63% perforation over that acute angle. In addition to, if we look at the septum, septum varies from 16 to 58%. We have different types of septum that could completely separate the sinus into two different chambers or just a narrow one, different kinds of septa. But we see perforation rate up to 44%. This almost means that if you do 10 sinuses, maybe 4 of them or 5 of them will perforate. So you have to be ready to manage that perforation so you're able to continue. And we see more of these septum more common anteriorly than we do on the posterior part of the sinus. Another part, the cortical wall thickness. Monhi talks about a higher perforation rate when the lateral wall thickness is less than 1.25 millimeter. And for obvious reasons, when you have a thin wall, the chances of you, as you're drilling, to perforate the sinus membrane are much higher, especially with unexperienced surgeons. The Schneiderian membrane thickness, surprisingly, a lot of studies, they look at the thickness, and they found that a happy medium is to have 1 to 2 millimeter thickness of that Schneiderian membrane. Anything less than that, and even more than 2 millimeters thick, they were associated with higher incidence of perforation. So that's another thing that we have to keep an eye on. And the sinus floor angulation. That's the one that I told you I'm very passionate about. Now, Cho et al., they discussed how having a narrow sinus anatomy with an angle less than 30 degrees, and that angle is measured between the lateral wall and the medial wall of the sinus, it was associated with higher perforation rate, up to 62%. If the angle was between 30 to 60, less of an acute angle, we have 28%. And if you have wider than 60, almost 0% sinus, 0% perforations. And in my cadaver study, we also noticed the same. We noticed having a higher chance of perforation and more localized of a vertical pattern of augmentation than rather than a flat, broad, kind of like dome-shaped augmentation when we have acute angle on the sinus floor rather than a flat. And this is the angle that I would like to look at between the lateral wall and the medial wall. This is the floor of the sinus, and this is the angle that I look at. If I have a 6 millimeter residual bone or 7 millimeter and I have that angle, I'm more concerned about doing a crestal sinus approach, and I have to be prepared for a perforation more than I am for maybe a 4 millimeter residual bone and a flat sinus floor. So this is very important to keep an eye on it and be prepared to manage possible complications. Now, how do we manage the sinus membrane perforation? First, one option is to abort. Is that an option? Yes. Do I want to do it? No. I try all the time, if possible, to fix the perforation of the sinus membrane. And my reasoning is the following. We have a lot of mentors and great surgeons that we listen to, and Michael Picus is one of them when it comes to the sinus augmentation. And he talks about that he never aborted one. I can't compare myself to Michael Picus, but what I can look at is, what if January of 2025, I get a perforation and I tell the patient, oops, I'll come back in 8 weeks and we'll redo it again. And we redo it, we get another perforation, a bigger one. What do? Am I going to abort at that time? Or I will try to fix and repair that sinus membrane. That's why I'll try to repair it, okay? So the other option would be we can use sutures. Sometimes that's more technique sensitive. We can use a membrane, and we'll discuss those membranes, and that's going to be a resorbable membrane for sure. PRF definitely can be used. A lot of people, they use it. I do not personally use a lot of PRF, but that's also a very good option. And we can do a buccal fat pad or a palatal rotating flap if we have an oral antral fistula or a communication. Now, I want to discuss a classification that Fugazuto did back in 2003 to classify and give a suggestion for how to repair the sinus membrane, okay? He classified the perforations according to the location of that perforation, either being class 1 or 2 or 3. And class 2, he gave it some subdivisions, and we will discuss them in a second. But generally speaking, class 1, it's when the perforation happens along the most apical part of the osteotomy or of the window that we have created. Class 2, when it happens on the lateral aspect of the prepared sinus window. And class 3, when it happens in the body of that prepared sinus window. And I will show you cases about each type of the classification. So class 2, he further divide that and into class 2A and class 2B. And to refresh your memory, we said class 2 is when it is on the lateral side of the window. So class 2A is if you have a perforation that you still have some room to go mesial or distal to it, 4 to 5 millimeter beyond that perforation, and be able to repair it. Class 2B is when you are out of space, you cannot widen your window, you cannot bypass that perforation, and that's a class 2B perforation, and I'll show you also a case. So this is generally speaking what you expect where that perforation will be, whether it's type 1, type 2, or type 3. Now, before I get into this one, I just want to quickly talk about also another, it's not a classification, but a case report by Michael Picus back in 1999 where he talks about how to manage perforation. Generally speaking, if you have less than 10 millimeter, most probably you can, and you can bypass it, you can do a resorbable membrane, and or if it's very small perforation, the membrane may overlap over itself as you bypass it. If it's larger than 10 millimeter, then we have to do something different, and I'll show you in a bit with some cases. So here we have a 3.3 millimeter of residual bone, and we want to go for a lateral window sinus augmentation and come back later on to place our implant. So we do the osteotomy, the window, and it's unfortunate I was not able to show it, but I had a very, very small perforation that it was on the apical part of this window. So what we do, now you can see here, this is the medial wall. We have to extend the release all the way to the medial wall, and we elevated the sinus membrane, and now the membrane has overlapped over itself, and it has kind of like repaired that membrane perforation on its own. But to sleep better at night and decrease the chances of problem or bone leaking through that small perforation, I will introduce in there an amnion-chorion membrane. I will get my baby membrane. That's what my assistants call it. So if I tell them get me BioExclude, initially they would tell me what. Then if I tell them baby membrane, they're like, oh yeah, the baby membrane. So that is the baby membrane. And why do we call it baby membrane? Because it comes from the amnion-chorion layers from the placenta that encircles the babies. And knowing what we know about the placenta and all the growth factors that it has encircling the babies, we use this membrane in the sinus membrane perforation. We have multiple layers. We have a lot of components from collagens, type 1, 3, 4, 5, and 7. We have laminins, fibronectins, proteoglycans, a lot of layers in those amnion-chorion membrane that will help and aid in our cellular migration and will aid also in the healing. So what happens is that epithelial layer on the top is removed, and it exposes that basement membrane, okay? And that's why this membrane, where you see the smiley face on it, right? It has no orientation. So you can fold it any way you want, you can place it any way you want, and do not trim it. You don't have to trim it. And I recommend that you do not trim it. And if you do trim it, please, the part that you trimmed, throw it back on the site, on the cervical site. It has all growth factors. You don't want to lose that. In addition to that, spongy layer is removed too. And by exposing the basement membrane, we expose the laminins and everything we have in those amnion layers and chorion, and that helps in expediting that cellular migration, okay? So you will see that there are some membranes out there that are amnion only without the chorion layer. And the reason why we like the chorion layer is, first, it is almost 4 to 5 times thicker than the amnion, and it has 4 to 5 times more growth factors and cytokines and chemokines that help with the regeneration process that we aim to get, and faster healing for sure. So that's why having the chorion layer attached to that amnion layer will help us in recruiting all of these cells and get a thicker membrane comparison to others that only have the amnion. And as you can see in this table, I'm not going to go over them, but a lot of growth factors, a lot of cytokines that you may recognize. You've read them in the literature. You know what they can do and what they're capable of on the in terms of inflammatory response and tissue healing. So we get our smiley happy baby membrane and we place it all the way to the medial wall. You want to make sure that membrane is placed dry, and I'll show you some videos. You do not want to wet it before you do it, otherwise it's going to make your life more complicated. And when you place it dry, it's going to stick to the sinus membrane and it's going to act like a nice glue that has glued that membrane together. So we place the bone. Here I'm going to skip quickly. I don't want to waste your time on that. That's not our topic. I do not have to show you how good I am in doing a crestal sinus, but I want to show you that we have contained graft. We have nice clean sinus. We're ready to place the implant. We get our implants in and we're looking good for 3 years follow-up. Everything's looking nice and stable. Now we get another case where we have 4 millimeter of residual bone. We have slight sinus thickening. We have a little bit of an acute angle over the sinus floor. I have a slight buccal deficiency where that implant needs to be prosthetically, so I'll have to do a GBR at that time. So we decided we'll do the sinus, we'll do the GBR, and we'll come back later to do the implant placement. So we do the window, and as you can see here, now we are placing same thing. We had a small perforation that was in the body of that window, so it's a class 3 perforation. So we're able to overlap it over itself. We go all the way to the medial wall. We make sure we have enough release to the medial wall, and we start getting our BioExclude membrane ready. So as you can see here, it is dry, and I will place it in the sinus cavity, and I will try to push it all the way to the medial wall before I allow it to stick to the sinus membrane, to the Schneiderian membrane, because I want to make sure if it sticks, it will make it a little bit difficult to push it more towards the medial wall. So I want to do that first, extend it to the medial wall, then let it rest on the Schneiderian membrane. The other thing is you can wet your instrument and manipulate the membrane as that instrument is wet, so the membrane does not stick to it, okay? And now that membrane is, the BioExclude is just part of that sinus Schneiderian membrane. It adapts nicely, and now we're good to go in and start placing our bone graft material and finish that part of the sinus augmentation, okay? So as I mentioned, we placed the bone. Here we were doing a simultaneous GBR, and this is what we have later. We have 8 millimeter wide bone, 15 millimeter of bone that is good to come back and place the implant. Now, what happens when we have such cases? We have maybe a 1 to 2 millimeter residual bone. We have a large mucus retention cyst. And if I want to do a lateral window, my concern is that if I don't remove that cyst, I may block out the sinus cavity by adding another 15 millimeter, 10 to 15 millimeter of bone. So I decided I want to get that out of my way. So using a sterile pencil, I draw where I want my implants to be, where I want my osteotomy for the window to be. And we go in, we elevate the sinus membrane, and we create a perforation. That's the time that I want to intentionally create a perforation, but the reason was to clean the sinus content from that cyst. Now here, if we look at how can we detect a perforation, uh, I see a lot of people talking about I believe I can fly and adding all these videos to and songs to their sinus augmentation. Meanwhile, they're showing that the sinus membrane is flying as the patient is breathing in and out. And here we ask the patient to breathe in and out. And with that amount of perforation, I expect the sinus membrane should not move, should not blink. But look as the patient breathes in, look what's happening. Do I have a perforation? Yes, I can stick my finger in that perforation. So that maneuver is incorrect or not 100% correct to be used to confirm that you do not have perforation. I prefer to use my visual inspection, symptoms from the patients, and at the end, a CBCT. So we go in, and this one, since I had a thick sinus membrane, I was able to suture it. So we suture the membrane together, and then I get my BioExclude. I tuck it into the sinus cavity, and here I wanted to act as a hero and try to place an implant at the same time, but I couldn't get stability. As you can see, I pulled it out. It's good to know your limitations at what you can do and what you can't do with these cases. And then we lay another layer of BioExclude over the window, and we close it completely for primary closure. And this is what we get back after we take CBCT a couple of months later. We can see sinus is clean, and we have had really good amount of bone that we have elevated. And now it's time to place the implant on that tooth number 3. Now, if you look at number 4, look what happened. This is how I started. Biology, biology, biology is very important. We get bone remodeling each time we raise a flap. Patient did not have any partial denture whatsoever. Patient did not have any infection, did not have any exposure, did not have any problem. And we get back the case like this. So it's very important to manage it. As you can see, we placed implant on number 3. We place a collagen xenograft on the buccal. We do a small like a layering or veneer graft, whatever you would like to call it. And then we lay another BioExclude membrane over the top, and we go for primary closure. And that comes back. We time for uncovery. We manage the soft tissue by doing more palatal incision, partial thickness dissection, apical repositioning, the flap without any need to do any gum grafting. And that's how we manage the soft tissue, and we send it back to the restorative dentist to finish this case. So we started from having a shallow vestibule with minimal KT to a better vestibule and good KT around those implants. Now, this one is a one where we have maybe 4 millimeter of residual bone. And sometimes all of us get that, where you want to place the implant at the same time with the lateral window. Sometimes finances, you may do part, the year after do the other part. Long story short, here we did just the sinus augmentation for a lateral window approach. Because if I wanted to think about it for a crestal sinus approach, there is an acute angle and there is a higher risk of perforation. But even with the lateral window, we had a perforation. And in that perforation, we have what Fugazuda classified as a class 2B. I tried to extend as much as possible to the mesial and we have reached the most anterior part of that sinus. So you can see the perforation is on the mesial or the most anterior part, and I'm trying to elevate the membrane. And as you elevate the membrane all the way to the medial wall, that perforation that is, let's say, a centimeter or two wide will close a little bit and shrink in size a little bit because you're reducing the tension on that Schneiderian membrane, but it is still there and it has to be managed. And we have to do something so I can continue the procedure and I don't have to abort it. So as you can see here, we have lifted the membrane, but I have the perforation on the mesial part. So this is where I'm getting my bioexclude. Now we tuck it in, again, dry, and as you can see all the way to the medial wall, and that's when I dip it to touch the Schneiderian membrane. Now, look, it's moving as one piece. As I ask the patient to breathe, the Schneiderian membrane, and mind you, that bioexclude did not completely seal the anterior part because we know that it will not seal it. I do not have other side of the Schneiderian membrane that this bioexclude will attach to both of them, okay? But what we're doing with the bioexclude, first, it is attaching to the sinus membrane. It's giving me all these growth factors that will help with the healing. Second, it is decreasing and making that perforation smaller. Instead of being a centimeter, maybe now it's a 5 millimeter or 4 millimeter or whatever. So it is smaller. So it's going to grab to the Schneiderian membrane, okay, and make that perforation smaller. And then, since this is a more complicated perforation, I will do the technique recommended by Michael Picos, where I will do a collagen membrane. He uses a cross-linked collagen membrane. Um, I personally use a non-cross-linked collagen, and I still have good results, especially that we're using xenograft, so that's helping with the space maintenance. And I have a first layer of that bioexclude over that perforation. So that membrane will be inside the sinus cavity, and it will act like a sealing over the Schneiderian membrane or the sinus cavity, and maybe it will extend on the anterior and the posterior sides of the sinus to kind of create like a small pouch, but it's not completely encircling the sinus like a Loma Linda pouch, where we found by research that that may have some compromised blood supply for the graft. So you still have the source of blood supply, but you're basically stabilizing and creating like a new roof over your head for that sinus cavity. And then we place the bone graft, bioexclude over the top, and we go for primary closure. And this is what we have. So it is very common when you do a sinus augmentation and you get a perforation and you take a CBCT post-op that you will see that the sinus is filled with fluid. That's normal. It's going to take the sinus a couple of weeks to drain that out. Patient will be on some decongestant. I'll discuss that towards the end, but this is pretty much normal. But we can see a contained graft. Everything is looking good here. Now we're going to get to the crescent sinus approach, where we have 6 millimeter of residual bone. We have acute angle, so we expect a higher chances of perforation. We do our osteotomy, we take final CBCT, we take a final preapical x-ray. Now, if you look at this one, you're going to say it looks perfect. I don't see any perforation. What did we talk about Dr. Abdelkarim Hamidan's study? We see overall 60% accuracy of the CBCT when we are looking at perforations, with 64.3 predictive value in the eyes of trained clinician. So CBCT is very helpful, but it cannot detect perforations all the time, because this one had a perforation, but we were able to manage it, and we were able to trick that CBCT scan and that periapical x-ray that that perforation did not cause an issue for us. So that's where the waffle cone technique came to mind, and I call it waffle cone because it looks like a waffle cone when you look at it from the top, from the occlusal view. And that bone graft putty in the middle looks like a vanilla scoop of an ice cream. And that waffle cone is going to be made out of bioexclude. Unfortunately, I can't get you an actual like chocolate dipped waffle cone, it has to be BioExclude for obvious reasons that I like to, which is first, it has growth factors, and I use a large size membrane, especially when I have to travel a long distance. So the whole concept of the technique, it's not it's not a new technique or out of nowhere. A lot of people, they may use collagen plug, collagen membrane. You can do that, but I have modified it in a way with the BioExclude that I want to push that bone and that membrane together with the osteotome or a condenser into the sinus cavity and keep the edges of the membrane over the crestal part of the osteotomy. So when I do that, I'm ensuring that the bone is contained by that membrane and still the edges are keep giving me a proof that everything is still in place where it needs to be. But if I stuff in a collagen plug, I will not know where that plug is. I'm not sure if that plug is going to go into the sinus cavity. So in doing it that way, I would get more security in that technique. And when we place the implant, we want to make sure that implant is placed on a slow speed, gently. You go in and you stop. You go in and you stop. And the other hand, your assistant might be holding the edges of the BioExclude over the crestal part. Okay. Do not lose sleep if those edges at some point start to peek in and go inside. That's normal. Okay. But that implant is holding those edges of the membrane and it's grabbing it. So everything is contained in between the implant and the membrane, and that bag of bone that's surrounded with the BioExclude is pretty much contained. And this is the CBCT after. And this is how we're looking after a couple of months of healing, and we send it back to the restorative dentist. Think about it this way. Yes, I have 6 millimeter of residual bone, and I'm placing a 10 millimeter implant. Am I really lifting 4 millimeter? No, I have to lift more than that because I wanted to sink my implant a little bit. Okay, so we're pushing the limit. If I don't do anything to manage that sinus membrane perforation, most probably, knowing what I know from my research, as that implant is going in, it may cause a perforation or do a tear on the side of the membrane and push some of that borne particles into the sinus cavity. So this way I feel more confident that everything is secured. Now, another case where we needed to extract this molar, we have this much of residual bone. Now, if we go back to what I have been talking about for the last 40 minutes, you're going to tell me, oh, but why did you want to go for crestal sinus? Meanwhile, you're talking about having a less than 5 millimeter. Most probably, we need to go for a lateral window. That's true. I have an acute angle. There's higher chances of perforation. That's true. But in this case, we decided that we want to go with crestal approach, patient on having some complicated health history, some blood thinners. And if you look at the thickness of the lateral wall, it's going to take forever to drill through that lateral wall. So I decided to go through the crest and knowing what I know and what I can do if a perforation happens. And sure enough, we have an acute angle. Guess what? We get a perforation, but lucky us, it was a small one. Now, starting with less residual bone, if I want to place a 10 millimeter implant, the distance that I have to travel is very, very, very big distance and very long distance that it will increase the chances of problems. So this is when I say I will place a shorter implant, but I'm still grafting, okay? Because I have 4 millimeter of residual bone. So we do the waffle cone technique again. We get the BioExclude, the putty, place the implant, and this is how the x-ray looks like. And this is 6 months after, and this is the scan after 6 months. Now, we talked about the scan. We may have a perforation, we may have no perforation, but sinus looks clean, bone looks contained. It's not an immediate post-op. This is 6 months after. So I feel confident that things are looking good at this time with no problem. So when it comes to crestal sinus augmentation, I always see how much residual bone I have, how much is the angulation of the floor, how deep do I want to place my implant, when did the perforation happen? Did it happen after I almost finished my lift and I see that now I have a perforation? If I have, let's say, a 6 millimeter residual bone and I have a perforation, there is an option to place an 8 millimeter without no bone graft, without anything. It may extend into the sinus and it may heal with no problems. A lot of studies have showed that it may heal with no problems. But when you have to travel a long distance and you can't just place an 8 millimeter implant on a 4 millimeter residual bone, you're exposing almost half of the implant into the sinus cavity. Now, I do not promote use exposing the implant into the sinus cavity, but if it happens, you have a millimeter or so, that might heal with no problems. But when you have to have half of the implant into the sinus, that's when I have to repair it. And I repaired it that way. The other way would be to go for a lateral window, elevate the sinus membrane, place the implant, and repair it with the lateral window approach. So here, this patient is on bisphosphonates, oral bisphosphonates, and she wanted to get an implant on that molar. Usually, I would do the extraction. If I can do immediate implant placement and a crestal sinus approach at the same time, I would do it. But patients with bisphosphonates, I try to gauge what I'm dealing with. What I mean by that, I try to do the extraction, let it heal, see how they heal, and if everything is okay, later on I come for the implant placement. So we take out the tooth, and I decided I want to prepare everything, get everything ready, so the implant placement later on will be a straightforward procedure. And we do the osteotomy for the implant using the osteodensification technique. We expose the sinus membrane. We have a small perforation. This patient was also on blood thinner, a lot of bleeding. You can see I had a hard time taking some pictures, but we also do the waffle cone technique. And this one, you don't have to use a larger size membrane because you're already halfway down in the furcation area. So I just need something to contain that bone graft for me, and we seal it. So this is post-operatively, immediate post-operatively after the sinus augmentation. And you can see I got like a mushroom shape type of crestal sinus lift. And you can see some liquid in the sinus cavity. And you can see actually a previous implant that was placed maybe 20 years ago, and it's resting in the sinus. Maybe 4 or 5 millimeter of that implant is in the sinus. But this is what we wanted to do at that time. And patient came back for implant placement. So we placed the implant, and you can see we have adequate bone around that implant, and everything is looking good. So we saved a procedure that was done at the time of extraction. And last case here today, where we, as you can see in the CBCT, you have a fully blown periapical lesion and some sinus issues, and we have the palatal wall exposed to the sinus cavity. So that tooth needed to be extracted, and we cleaned it out, and the palatal wall, palatal root, where that root was, where we have the communication with the sinus, the picture might not be giving it its credit, but we have lined it, the inner part of it, with the BioExclude, and then we place the bone graft, and this is the CBCT immediately post-op. So we're able to contain the graft, and I'm getting the growth factors out of that BioExclude. So what do we do post-operatively? Patients will be placed on antibiotics. I will discuss the antibiotic regimens and pain medications. We recommend stuff, but sneeze with your mouth open. No smoking or drinking. We recommend do not exercise for a week. And if any patient tells you, oh, I can't do that, I want to exercise, just tell them I have not exercised for 15 years and I'm still okay. That's me, so that's what I use. Sinus decongestant, definitely recommended. Flonase, Sudafed, anything over the counter, they can use that twice a day for the first week or 10 days. Do not drink with a straw, do not blow your nose, and do not play with any instruments, and do not open your mouth widely. Soft liquid diet. Anything they can cut with a plastic fork is something that they can eat. That's what I tell my patient. And they can brush the area with a surgical brush, but that's not until a week or 10 days. and they're going to have symptoms afterwards. That is normal. They're going to have some fluid coming out of their nose, maybe blood. I will be concerned if I start to hear from them there's bone particles coming out of the nose, or if pus is coming out, or a bad taste or smell. That's when I would be concerned and I would need to check on that patient. It's very important to keep them on regular follow-ups. I do 1 week, I do 1 month, and then I see them once a month until they're ready for the next phase. Antibiotics, I do augmentin, the amoxicillin and clavulanic acid twice a day for 10 days. If patient is allergic, I do metronidazole and clarithromycin. That is recommended by Tistori. Dexamethasone, I don't do that much. If you want, some may use steroids. Just be careful with diabetic patients. For the rinse, either you can use chlorhexidine, Paradix, and if you have access to Stella Life, I like that one. I use it also too. Ibuprofen, 800, or acetaminophen or Norco, whatever pain medications you like to give the patient, and a nasal decongestant. And by that, I want to sum it up. These are my emails, my social media. Please reach out to me if you have any questions. I'm more than happy to help. And thank you again, Matt, for having me.
Yeah, Doc, thank you. Thank you so much for being on. I really appreciate it. We'll leave the Q&A open for a few minutes in case anybody has any questions they'd like to share. And I'm going to take over screen control real quick here. If anybody is interested to learn more about the Maxius portfolio, including BioExclude, there's a QR code there that'll take you to our website. Again, I'd encourage you to get on regardless to learn a little bit more about our organization and our mission. And Doc, thank you so much. That was a fantastic presentation. I'm gonna jump over here to Q&A real quick and see if we have anything coming through. Nothing yet. So
Awesome. So I think I did a good job.
exactly.
I hopefully answered all the
Exactly.
questions that they have.
Yes, exactly. So, well, Doc, thank you again so much for your time this evening. Always great to see you. Oh, looks like we may have some Q&A here. We got a chat. Thank you, Doc. Amazing presentation and great clinical skills. Where do you get the membrane in Canada? Currently, we've been working with Med as our Canadian distributor. They're based in the Toronto area, I believe. So if you scan the QR code, or you can reach out to me, I'll put my email in there. I can connect you with them. Another question coming in. What size membrane do you use for the waffle cone technique? Do you have any articles to show the success of this technique?
That's a great question. Hopefully, the first article will come out is mine because I kind of came up with that. So, paper is about to be submitted for review. So I don't have literature to support, but all what I have is case reports. Hopefully, we get more people to pile in. So I thank Dr. Daniel for that question. Now, the size, as I mentioned, it depends on how much I have to travel. Okay. If I have a 3 or 4 millimeter off residual bone and I'm doing a crestal sinus augmentation and I want to place an 8 millimeter implant, I'm traveling a long distance that I would want maybe a 30 by 40 size or a 20 by 30 membrane. That case where I showed the extraction time, it's inside the socket in the furcation area. So from the furcation to the floor of the sinus, there's not a lot of distance that I have to travel. So I'm okay with a smaller size membrane. But generally speaking, I stick to the largest two sizes of the BioExclude. So I'm getting that leverage to keep the edges of the membrane over the crestal part.
Yeah, those largest two sizes would be the 15 by 25 and the 20 by 30.
Yeah, don't you have a 30 by 40 or you stopped that?
No, not yet, but we're always open to suggestions.
Please, yes. Then 20 by 30 then.
Why, with the waffle cone technique, you don't need to suture the bioexclude onto the perforated sinus?
Why with the waffle cone technique?
With the waffle cone technique, you don't need to suture the bioexclude onto the sinus, is the question. You don't.
Okay, so I'm not sure that I'm getting but here's what I would answer. The waffle cone technique, when it's done during crestal sinus augmentation. It's not when you do it in a lateral window. So I do not have access to do any suturing. Suturing is always done when you have access to the sinus membrane, and that will be when you're doing a lateral window. So I'm not sure if the doctor is asking why did I use a BioExclude for the case that I showed that I sutured the membrane. Maybe they're asking about
Well, he
that
was. I think he was asking why don't you need to suture it to the Schneiderian membrane, the bioexclude.
because I have no access to do so. No, nobody has access from the crestal osteotomy, a 4 or 5 millimeter wide osteotomy. You do not have access to suture membrane to the sinus Schneiderian membrane. But I can suture, and it's not easy when I'm doing a lateral window and I have a larger window that I can access the sinus Schneiderian membrane.
Patients that get the foul smell, when do you send those to the ENT?
Okay, so usually I would not send them to the ENT yet. What I will do is I will take a new CBCT, see what's going on, put them on another round of antibiotics. Okay, if they were on the augmentin, I'll switch to metronidazole and the clarithromycin, and I will bring them back. I'll keep an eye and I'll see if symptoms don't go away and they still have it. I may just say, hey, it is what it is. I'll open it. I'll get the graft out, rinse the sinus out, clean it, and then come back later to do the procedure again. Sinus graft infection happens 2% of the time, what we know from the research. It's an urban study. So it may happen. And sometimes we do everything perfect, no perforation, sinus augmentation perfectly great. Come back after a month, we have infection. So it happens.
I like this one. With the waffle cone technique, does the bioexclude interfere with implant healing? Why does the barrier membrane not inhibit bone implant contact?
Beautiful question. That could be Panos. Is that Panos?
No, no, it's not Panos.
Okay, because he asked me that question before. That is a very, very good question. Honestly, I can't answer it. The only way I can answer it is if we take a blood graft and do histology, but in 2025, we can't do that anymore. Maybe some animal studies can be done, but the couple of cases that I've done it, I touch wood, did not have any problem with implant osseointegration, and everything worked well, especially knowing the resorption time of the BioExclude and how thin it is. Um, and it has growth factors. That's why I would feel it, I don't know if it may help me with osseointegration, but up to now, it did not interfere with osseointegration. But that's a very good question and scary question because if it happens, I'll be concerned. But thank you for the question. Definitely.
With an infection, what's your protocol? Do you excavate the graft, drainage?
Honestly, I don't immediately go in and excavate it. As I mentioned, I would put them back again on antibiotics, depending on when the infection happened, put them back on antibiotics, take a CBCT. If the case is not improving and patient's still having symptoms, then I'll just go in and take it out as soon as possible.
All
Because
right, main
another thing,
diff.
sorry to interrupt, but
No,
the
go ahead.
last, I would say 6 weeks or 2 months, for some reason, God sent me a lot of sinus cases. And at the same time, He sent a new variant of COVID or something going on. So most of the sinuses that I've done, a couple of days after, even though I had no perforation, they all had starting to have symptoms. And they overlapped between COVID or being sick during Christmas time and the sinus augmentation. So sometimes you may have to wait it out a little bit, make sure the patient does not have any other diseases going on, um, uh, so you can make a better judgment.
What type of bone graft do you recommend for the waffle cone technique?
I personally prefer to use the putty bone for any crestal sinus augmentation. And that's just a personal preference because I like the hydraulic pressure that I get from the putty bone, that it's smooth particles and it allows me, as I mentioned, I use the osteodensification technique, but I don't follow the protocol. I do some changes on it, some modifications, and I make my bone do most of the elevation.
Perfect. A number of thank yous, awesome lectures, questions about getting the product in Australia. Again, I dropped my email into the chat there. Email me. I can put you in contact with our international team, and they might be able to answer some of those questions for you. But hey, we're right at 7 o'clock, right on the hour, Doc. Fantastic job. It's always great to see you.
Thank you.
I guess I'll see you hopefully before, but if not, I'll see you in Toronto here later this year.
Okay. Thank you very much, Matt. Appreciate you.
All right. Take care, everyone. Thank you. Bye bye.
Take care.